There is a crisis unfolding quietly inside hospitals, oncology wards, and emergency rooms. A pattern so subtle that most people don't see it until it touches someone they love. Across the United States, and in parts of the world connected to the same fragile supply chain, 247 pharmaceutical drugs are in documented shortage. Antibiotics, anesthetics, steroids, pain treatments, and, most alarming to many analysts, multiple frontline cancer drugs. Here's what nobody tells you. Modern medicine looks invincible from the outside, but it is one of the most fragile systems ever built. It runs not on technology alone, but on timing, logistics, ingredients, and global stability. If anyone link in that chain weakens, lives change instantly. This is where the pattern begins. Throughout history, medicine shortages have always followed the same emotional and economic sequence. In 1918, during the global influenza pandemic, quinine and aspirin supply collapsed across Europe. In the 1940s, penicillin shortages forced rationing during World War II. In 1973, when oil shocks hit the world, pharmaceutical production stalled because factories couldn't transport raw materials. Each crisis revealed the same uncomfortable truth. Even life-saving drugs depend on supply chains as vulnerable as food, fuel, or electricity. Now, in the early 2020s, analysts suggest we are watching the early phases of a modern pharmaceutical stress cycle. Not a guaranteed collapse, but a scenario shaped by the same vulnerabilities that triggered past shortages. Let me show you exactly how the emotional chain reaction begins. It starts with a single patient. A doctor opens a chart and realizes that the recommended chemotherapy drug, the one with the best survival data, is unavailable. Not reduced. Not delayed. Gone. The doctor must choose a second best option, or a third. Families look for answers. Nurses scramble to locate remaining vials. Pharmacists whisper about allocations. The hospital contacts suppliers. Suppliers contact manufacturers. Manufacturers wait on raw materials from overseas. At first, it looked like a miracle. Modern healthcare could handle anything. Then the bill arrived. The second phase of the chain reaction hits the system itself. Hospitals begin rationing doses. Treatment cycles are modified. Delays ripple across oncology programs. Insurance companies adjust coverage for substitute drugs. States activate emergency procurement. Patients form support groups online, sharing stories about driving hundreds of miles to find a medication their doctor once took for granted. And here's why this matters. Shortages don't stay isolated. They spread. One missing cancer drug increases reliance on another, pushing that drug toward shortage too. A shortage of a single anesthetic forces hospitals to use alternatives, which then run out. The system cascades. Everyone thought they were safe. They weren't. Because the danger wasn't what they saw, a missing vial in a cabinet. It was what they ignored. The fragile chain of manufacturing, transport, and global economics that kept that vial in place. To understand why this pattern forms, we need to rewind to historical case number 1, the wartime shortages of the early 1940s. When World War II erupted, penicillin became the miracle drug soldiers depended on. Demand soared. Factories ramped up production, but raw materials were limited, and transportation routes were vulnerable to blockades. Prices rose. Hospitals rationed. Researchers raced to optimize yields. The lesson was clear. Medicine is only as strong as the supply chain behind it. Historical case number 2 follows the 1970s, the decade when supply chain fragility became impossible to ignore. The 1973 oil crisis didn't just raise fuel prices. It dismantled the pharmaceutical logistics network. With shipping slowed and petrochemical inputs in short supply, medicine inventories collapsed. Pharmacies rationed everything from antibiotics to insulin. Governments intervened, and for the first time, analysts began to warn that modern healthcare depended heavily on cheap transportation, foreign suppliers, and energy stability. Here's what nobody tells you. Every medicine shortage in history has followed the same economic pattern: a spike in demand, a break in the chain, and a scramble for substitutes. But something new has emerged in the 2020s. The shortages are not caused by one event. They are emerging in clusters. Let me show you exactly how this modern cluster formation works. First, manufacturing has become globally concentrated. According to multiple analysts, over 80% of active pharmaceutical ingredients, APIs, used in the U.S. originate in just a few countries. When a factory overseas pauses production due to contamination, weather, labor issues, or regulatory shutdown, the ripple spreads across continents. Not production, reliance, not diversity, fragility. Second, generic drug manufacturing has razor-thin profit margins. Some companies discontinue life-saving medications because they are no longer profitable. Others prioritize higher-margin products. When one company exits the market, a shortage forms instantly. Third, demand spikes, from flu seasons to global disruptions, push inventories below safe levels. A single winter illness wave can exhaust supply lines months before replenishment arrives. Here's the trap. The modern pharmaceutical system was optimized for efficiency, not resilience. It was built to deliver millions of doses cheaply and quickly, but not to withstand multiple shocks at once. And as shortages increase, the emotional dimension deepens. Parents in pediatric oncology units notice differences in treatment plans. Nurses begin guarding supply closets. Surgeons reconfigure which anesthesia combinations they can offer. Hospital administrators call suppliers weekly for updates. Some analysts argue we may be witnessing the early stages of a systemic supply shock, not catastrophic, but expanding quietly beneath the surface. This raises a question that sits at the heart of this documentary. What happens when a healthcare system built on abundance begins to operate in scarcity? Because the most dangerous phase of this story hasn't begun yet. The next section moves from symptoms to structure, exposing the deep mechanism behind pharmaceutical shortages and the scenarios that may define the next decade of medicine. Here's the mechanism behind the modern pharmaceutical shortage. The global drug supply is not a single system. It is a chain of interlocking vulnerabilities, manufacturing bottlenecks, fragile shipping lanes, price pressures, offshore dependency, regulatory choke points, and ultra-thin profit margins, all stacked together like dry timber waiting for a spark. Analysts studying the 247 drug shortage list argue that the crisis isn't random. It follows the same structural weaknesses that destabilized other industries long before medicine began to feel the shockwaves. And once the chain starts to tighten, it pulls every link with it. To complete the historical parallels, we return briefly to the post-1970s world. After the oil shocks, pharmaceutical companies began cutting costs aggressively. Manufacturing moved offshore. Factory specialization increased. Nations with lower production costs became the backbone of the global medicine supply. For decades, it looked like a victory: greater output, lower prices, expanded access. At first, it looked like a miracle. Then the bill arrived. Here's what nobody tells you. Cost efficiency always comes at the price of resilience. When globalization surged in the 1990s and 2000s, supply diversification collapsed. Instead of 50 factories making a cancer drug, only a handful did. Instead of multiple countries producing antibiotics, production consolidated into a tiny cluster in Asia. Companies believed they were optimizing profits. In reality, they were concentrating global risk. Now, look at historical case number 3. Even outside medicine, we've seen the same pattern play out in critical industries. When the 2011 tsunami struck Japan, microchip production collapsed. Countries worldwide felt the shock for years. When the Suez Canal blocked in 2021, global shipping lost billions in a week. When rare earth exports tightened in the early 2010s, technology manufacturers scrambled for alternatives. Each crisis shared one theme: concentration magnifies weakness. And this is where the pharmaceutical pattern becomes visible. Let me show you exactly how the modern system breaks down. Step 1. Ingredient fragility. Most essential drugs rely on active pharmaceutical ingredients, APIs. Some analysts estimate that up to 90% of these ingredients are produced in a few major manufacturing hubs. When one facility pauses production due to contamination or maintenance, global supply drops instantly. Even a delay of weeks can cause ripple effects for months. Step 2. Manufacturing bottlenecks. Once an API shortage begins, manufacturers cannot simply scale up. Pharmaceutical plants require strict sterilization, specialized equipment, and regulatory approval. A single plant closure forces every other plant into overdrive, and that strains their capacity too. Not growth, overload. Step 3. Low-profit generics. Here's the trap. Many of the drugs in shortage, including cancer treatments, are generics with extremely low profit margins. Companies often choose not to invest in redundancy. If a factory breaks down, no competitor jumps in to fill the void because the financial incentive is too small. The market fails precisely where patients need reliability most. Step 4. Sudden demand spikes. A harsh flu season, a rise in childhood illnesses, or a surge in cancer diagnoses can push inventories over the edge. Hospitals order more. Suppliers ration. The system buckles. Everyone thought the supply chain was built for emergencies. They weren't. The danger wasn't what they saw, shelves thinning, but what they ignored, the narrow buffer beneath them. Step 5. Cascading substitution. When drug A disappears, doctors switch to drug B. Then drug B enters shortage. Now drug C is pressured. The entire ecosystem becomes a domino chain. Here's why this matters. Pharmaceutical shortages do not escalate linearly. They accelerate. This brings us to the emotional core of the crisis: who loses first? Cancer patients are among the most vulnerable. Some frontline chemotherapy drugs, like cisplatin and carboplatin, have faced prolonged shortage waves. Pediatric oncology units report treatment delays. Some patients travel across states for a single dose. Oncologists substitute older, less effective regimens. Families endure uncertainty that science solved decades ago. Emergency medicine suffers next. When anesthetics or pain medicines run short, surgeries must be rescheduled. When sterile injectables tighten, hospitals ration them for trauma cases. Pediatrics is hit hard. Liquid antibiotics, pediatric pain relievers, and specialized formulations are often the first to disappear because they are manufactured in smaller volumes. ICUs feel the pressure. Critical care drugs, vasopressors, sedatives, electrolytes can run low when the system strains. But not all regions suffer equally. Some countries adapt better because they maintain domestic manufacturing capacity. Others build strategic stockpiles. Some create rapid response procurement networks. Nations with diversified supply chains absorb shocks that destabilize others. Nations with concentrated supply chains face scarcity first. And now we arrive at the crossroads: the future. Analysts outline several possible scenarios for the next decade. Not predictions, but conditional outcomes shaped by policy, economics, and global coordination. Scenario 1. Stabilization. Through investment, governments incentivize domestic manufacturing. Redundant plants reduce concentration. Regulations streamline approval for alternative suppliers. Raw material sourcing is diversified. The shortage wave recedes within years. This scenario requires political will and financial investment. Scenario 2. Rolling shortages become normalized. Under this scenario, shortages continue in cycles. Some drugs return to full supply while others fall into scarcity. Hospitals adjust. Treatment plans evolve. Patients adapt. The system functions, but always under strain. Analysts view this as one of the more realistic near-term possibilities. Scenario 3. Regulatory overhaul. Governments introduce new frameworks for essential medicines. Price floors increase profit margins for generics. Foreign dependency decreases. Supply chain mapping improves. This scenario does not eliminate shortages, but it reduces intensity. Scenario 4. Severe systemic disruption. Low probability, high impact. This scenario imagines multiple shocks occurring simultaneously: a major manufacturing shutdown overseas, a transportation crisis, an economic downturn, and a spike in demand. Shortages expand from hundreds of drugs to thousands. Treatments are rationed. Hospitals triage based on availability. Analysts model this scenario to understand vulnerability, not to predict it. Here's what nobody tells you. The pharmaceutical crisis is not about medicine. It's about infrastructure. It's about the invisible systems beneath modern life that remain stable only when everything else is stable too. Here's why this matters. The ability to create and deliver medicine is one of the defining powers of civilization. When that system strains, society feels it at every level: health, economics, trust, and mortality. Let me show you exactly why patterns matter. Every shortage, from the 1940s to the 1970s to the 2020s, followed the same structure: concentration, shock, substitution, acceleration. History doesn't repeat itself because we fail to learn. It repeats because incentives remain the same. If this documentary opened your eyes to how fragile the pharmaceutical world truly is, and how a system built on saving lives now depends on global chains stretched thin, then the lesson is clear. To secure the future of medicine, we must rebuild the foundations that make medicine possible.